Pretty good. Pretty
So
good.
this lecture, we will be talking about valvular heart disease, and mainly we will be
Hmm.
talking about rheumatic fever.
Yeah.
Rheumatic fever. Great. So, it's historical or maybe epidemiological introduction. Rheumatic fever is very common. It affects around 500,000 new cases every year. Uh, and it's endemic in Egypt, by the way. I believe you are in the
Mhm.
Caribbean, right?
Yeah, yeah. That's where I'm at right
Yeah,
now.
yeah, it's endemic in some parts of the Caribbean, and it's very endemic in Egypt. I have seen a lot of cases of rheumatic fever and rheumatic heart diseases. By the way, rheumatic fever is very different from rheumatic heart diseases. Rheumatic fever has many symptoms. One of them is rheumatic heart disease. So, not every patient of
Gotcha.
rheumatic fever should be
It's
having a
gonna have
rheumatic heart
the
disease. Yeah.
yeah. Okay.
Okay. So, we have 47,000 rheumatic fever cases, but just 280,000 rheumatic heart disease case, because not every rheumatic fever patient is having
We'll have
rheumatic
it. Yeah.
heart disease. Yeah,
Gotcha.
yeah. Uh, um, many patients die from it, but if someone got rheumatic fever, that doesn't mean his heart is dying. It takes hundreds of attacks and many years of attacks for rheumatic fever to develop rheumatic heart disease. So it's actually that's why it's a disease of developing countries. So because if you have good health service, you are
You can
preventing
take care
further
of it.
attacks of rheumatic fever, then the patient would be more than fine. But if you don't have penicillins and don't have good health service, then the patient would be getting into rheumatic heart disease and end stage failure. Egypt
Gotcha.
has 5 to 8 million cases. I believe Caribbean is much lower, maybe less than a million case. Um, Globally, most common etiology of mitral stenosis, by the way, rheumatic, I believe it's mnemonic I've just invented, Rheumatic affect mitral,
Uh-huh.
then the aortic. So mitral first, the first valve to be affected is the mitral. Most common valve to be affected in rheumatic cases is mitral. Aortic is the second most common. And by the
Versus
way,
mitral than aortic. Okay.
it rarely affects left side. Because right side has more pressure. So it rarely affects the right side. It affects almost only the left side of the heart. Uh, it's very rare to cause a mitral disease or mitral stenosis or even regurgitation in high income countries because they have a better health service, and it needs years of attacks of rheumatic fever just to for the heart valve to be affected. In high income
Gotcha.
countries, you have just got rid of rheumatic fever, so other causes such as calcific heart disease of long age, of old age, infective endocarditis, radiation, and congenital becoming the most common. Okay, GAS.
Yeah, group A strep hmm.
Okay, so could you please like tell me,
Like, say what I yeah.
yeah, tell me about mimicity and this thing, and why a patient is having GAS infection and is getting heart disease. What's the relation? How could this occur?
Yes. So basically you have it's via molecular mimicry. So you have the group A streptococcus is going to begin causing that like rheumatic fever.
Hmm.
And over time, the immune system is going to activate and it's going to try to kill the infection. Um, However, like these antibodies that are produced, they have like the same like M protein, I think it's called. I think it's the M protein.
Yes.
That is the same as the heart valve. So rather than actually, or not rather, but like as well as eliminating the pathogen, it also attacks the heart valve, causing that valvular heart disease.
Hmm. So it's just the heart valve?
I guess yeah, as far as I'm aware, it's only the heart valve.
No,
Oh, okay.
it's
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 everything.
attacking our cells. So it's attacking our bodies. And
Gotcha.
And mainly, we 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 gather it in it's called Jones criteria. You know Jones
Yes.
criteria?
Hmm.
Great. I believe it would be great if you could write this mnemonic. It's great mnemonic. So J for joint. Rheumatic fever would be in
Joint
rheumatic fever,
issues. Yeah.
our antibodies would be attacking our joints. So J for joints. It would be causing joint inflammation. And inflammation include redness, hotness, and pain. So first, joint inflammation. Second one
Joint inflammation.
is O. O is very similar
Cardiac.
to the heart, you know?
Yeah. Yeah.
So it's carditis. It's cardiac inflammation and mainly the valves, not the heart muscle itself. It's mainly the valves. The valves are the ones that's pretty similar to the GAS bacteria. And in the subcutaneous tissue, it's called nodules or subcutaneous nodules. It's number three, subcutaneous nodules.
Venous nodules.
Okay, and for E, it's affecting the skin or attacking the skin. It's causing something called erythema marginatum. So here nodule for N, and here erythema for E. Erythema marginatum. You know erythema marginatum?
I think. Yes. Yes. Yes.
So what it look like?
It's like Oh wait, no. It's not the one that's in Lyme disease. That's erythema. It it's like a erythema
Erythema in the
margin. Yeah.
margin.
So it.
The margin,
Mm,
yeah. Yeah, that's it. That's marginal erythema. Marginatum in Latin means in the margin.
okay.
Great. So, and for S, what's the fifth main organ that's being attacked in rheumatic fever? S. So four, erythema marginatum, and five. Mhm. S.
S. Wait, Jones. Dang, I don't remember what the S is. It's no, no, that's the infective
You know, we have Korea left.
subcutaneous.
We have Korea left, right? Korea. You know
Yeah,
Korea?
yeah, yeah, yeah. It's
But
like the like rhythm like movements or dance like
yeah,
movements.
yeah, that's it, Korea. Rhythmic,
Hmm.
yeah, jerky movement. But we could call it Sydenham's Korea. It's another name for it, Sydenham's. I believe it's the one who have discovered it, I believe, or it's, Sydenham's Korea. So joint inflammation. And by the way, those are the major criteria for rheumatic fever. The organs that are
Jones
being attacked
criteria.
are also the same as the major criteria. So joint inflammation is one major criteria, but joint inflammation, not just joint pain. Inflammation include pain, redness, hotness, tenderness. So it's a major criteria. Joint inflammation, major criteria number one. Carditis or cardiac affection, major criteria number two. Subcutaneous nodules, major criteria number three. Erythema marginatum, major criteria number four. And Sydenham's Korea or Korea, major criteria number
Erythema
five.
syndrome.
Yeah. So if if I wanna diagnose rheumatic fever, could you tell me what is a single symptom that could let me be assured that it's a rheumatic fever?
Yeah, just in general, right? Not just about Jones. Like a new onset heart murmur is kind of what I'm familiar with as being the biggest thing for rheumatic heart disease.
So 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 if I have a nuanced heart murmur, I would be sure that I have a rheumatic fever.
I mean, at least in a question stem, that's what I'm associating it with.
So
Um,
mhm. So in diseases like rheumatic fever, when we are making criteria for diagnosis, So we don't have a single symptom that I could be sure that it's rheumatic fever. So I need more than
It's
one.
a
I need
combination of things.
two
Gotcha.
major, or one major and two minor. You know minor criterias?
It's just like the uh common symptoms you can find kind of anywhere else.
Yes, yes,
Like fever or such as
yes.
that.
Fever. What else?
Fever,
Elevated ESR
hmm,
and CRP. Fever could be
often the
found
inflammation.
in any infection. Elevated ESR and CRP could be found in any infection. That's why it's a minor. I need two of them and one major or two major criteria. It's minor. You know, it could be found in any infection. If I have the five major minor ones, I couldn't be diagnosing rheumatic fever because it could be found in any infection. Fever, increased
Yeah, it's
ESR
too
and CRP,
generalized.
arthralgia.
Gotcha.
Arthralgia. You know arthralgia?
Arthralgia. It's like joint issues, arthralgia,
Joint pain. Algia in
joint
Latin
pain,
means
joint pain.
pain. So arthralgia means joint pain, but it's a minor criteria. If I have arthritis is the major one. Arthritis, I have joint pain, redness, stiffness, joint inflammation. It's more than joint pain, you
Yeah,
know?
yeah,
Fine. Okay.
gotcha.
So fever, increased ESR and CRP, arthralgia. So if I have two major criteria or one major and two minor, could I be diagnosing rheumatic fever?
Two major criteria or one major, two minor?
Mhm.
One major. Yes.
No. Why? Because there is,
Oh, you can't.
because there is something that many people miss. For diagnosing rheumatic fever, I should have evidence. Beside two major or one major and two minor, you know, I should have evidence of GAS infection, evidence of GAS infection, because the cause of rheumatic fever is only GAS infection. So I should be having like a throat culture, a throat swab and culture. I should be having antibodies for streptococci or something in the blood. But I should be having this evidence plus two major, or this evidence plus one
One
major
major, two minor.
and two minor. So please
Gotcha. Okay,
don't
okay.
don't forget that I should be having evidence of gas infection. Okay,
Gotcha.
I should be having it, and for sure it would be preceding the attack of rheumatic fever. So if it's infection in the pharynx, it would be almost 2 weeks before the symptoms is starting rheumatic fever. And by the way, gas it's most common to cause infection in the pharynx, but it could be causing a skin infection, cellulitis. You know
Skin infection
cellulitis?
as well.
Yeah, gas could be
Yes,
causing
yes, yeah.
cellulitis, and as a
Gotcha.
complication of this cellulitis, it could be causing um, rheumatic fever also. By the way, it's not mentioned in your lecture, but it's very important to know it.
Okay.
Great. So we have covered this. Uh, so yeah, we are focusing on the heart, but rheumatic fever is not just the heart. Uh, Fine. This is a rheumatic fever patient, and this is the heart valve affected. Okay, two major or one major and two minor. And don't forget, I don't know why it's written in a very small font. You should have an evidence of recent group A beta streptococcus infection.
Infection as well.
Should have evidence of this.
Gotcha. Uh-huh.
So major, you could write Jones criteria. It's the same as Jones. So J, arthritis, and it's migratory. So the patient feel the pain right here today. Tomorrow he will be feeling it right here, and will be feeling it right here the day after. It's migratory. It's like migration, fleeting.
Yes. Yeah.
So J, O, carditis, N, nodules, E, erythema, and C, S, Sydenham's chorea. Minor, as we have talked about, it's like general signs of infection, but PR prolongation is a very high yield info. PR interval
PR
prolongation.
prolongation.
Yeah,
Okay. For rheumatic fever. Gotcha.
yes. Great. So we'll be having group A beta pharyngitis or skin infection. If it's pharyngitis, then it's 2 weeks, and then the patient would be having acute rheumatic fever. If he is genetically susceptible, for sure, because maybe many people is getting group A pharyngitis and not getting any rheumatic fever. It's genetic susceptibility. 2 weeks, he would be getting acute rheumatic fever, acute attack. For sure, acute attack wouldn't be causing any heart problem. It's just some inflammation. But if we have current attacks of rheumatic fever, he would be having chronic heart disease, and they take years. So on average, patient is diagnosed with rheumatic fever when he's 3 year old. But on average,
Mm-hmm.
also, he's diagnosed with rheumatic heart disease when he's 30 year
At
old.
30. Yeah.
Yeah, so it takes a lot
Takes
of
over,
years.
yeah, decades. Gotcha.
Okay. Rheumatic fever. So I believe there is, rheumatic fever is the disease or the injury, and rheumatic heart disease is the scar of this injury, the scar. That's it.
Mm-hmm.
Okay. You'll be hearing murmurs, and yeah, you should be taking past medical history if he has got rheumatic fever attacks in the past. So he maybe an old man, and just because he like remembered he got attacks of rheumatic fever in the past. So yeah, I could be suspecting it's a rheumatic heart disease. Hemodynamic response. Yeah. Okay. Um, so yeah, it's the ejection between systolic and the systolic, or S1 and S2. It's the systolic phase, and this is the systolic one. And here we are starting a new systolic. It's just a uh,
Yeah.
normal diagram of the normal flow. Here it's the valves. It's tricuspid valve, three cusps, tricuspid. Right here it's two cusps, so it's mitral valve. I believe those are the aorta and pulmonary. Okay, if it's it's affecting the mitral, then the aortic. It could be mitral stenosis
Yeah.
or regurg, and aortic stenosis or regurg. If it's regurg,
Okay, so it doesn't
then it
matter.
would,
Yeah, gotcha.
yeah, it's regurg, it would be causing volume overload. If it's stenosis, it would be causing pressure overload.
Pressure.
Don't
Mm-hmm.
don't don't forget that volume overload is systolic heart failure, and pressure overload is what?
Diastolic.
Diastolic, yes. It's like going to the gym. We have stenotic,
Yeah.
very hard to push through.
Inflammation. Yeah. Mm-hmm.
Yeah. So normally the pressure in the ventricle reaches 120 in systole, and it reaches also in the aorta 120 in systole. And the diastolic is 80 in the arteries, including the aorta, but it's around 10 or 15 in the left ventricle. And when it's 80 here and it's 10 right here, what prevents blood from coming back? It is just the aortic valve closing. So it prevents blood from coming back from high pressure of 80 in the diastolic phase to low pressure of ventricle
Low
in
pressure,
diastolic
10.
phase. Yeah.
Yeah. Gotcha.
Uh-huh. Okay. Aortic stenosis. Um, so in the in mitral, it's most common regurg. It's most common to be affected by regurg. And aorta, it's most common to be affected by stenosis. I believe anything written most common should be for an MCQ. You should know it very well because
No,
uh,
gotcha. Okay.
okay. So in congenital disease, it would be starting from day zero of life, maybe, and you wouldn't discover something congenital beyond 30 years. And in
Yeah, you wouldn't
degenerative
know
disease of
immediately.
old age, it's more than 60 years for sure. Yeah, it's a wear and tear of the valve. So we have used it for more
Mm-hmm.
than 60 years in degeneration would start. Bicuspid, some sort of congenital, but it's working valve. It's good valve, but just bicuspid. It's not three valve, three cusps. It's just two. It's working valve, but it would be have affection around 30 to 60 years. Pretty similar to the rheumatic. Rheumatic also around 30 to 60 years. So you should be differentiating bicuspid from rheumatic, and we could see it through echo. Echo, we are seeing the heart through echo. Okay, so aortic stenosis. The pressure in the left ventricle, normally it's 120 here and 120 here.
Hmm.
But in aortic stenosis, we have to push very hard. So it would be 200 in the left ventricle. And we couldn't deliver all this 200 uh, pressure to the aorta because it's stenosis. So it would be less than normal, 110, 100 in the aorta.
I didn't get its full
Yeah,
amount. Gotcha. Yeah, yeah, that makes
that's
sense.
aortic stenosis. And because of this generation of high pressure, I would be increasing the thickness. I go into the gym. You have talked about it a couple of times.
Yeah.
Increased thickness of the left ventricle, which is would be a great compensation at first, but then the blood coming to the left ventricle muscle wouldn't be enough, so we would be having multiple infarctions, and it would be a weak muscle at the end. So here is no stenosis, normal width of this or diameter of this aorta between 3 and 5, and it's as regular. We have a lot of reserve. We have a lot of extra space in every extra potential in every organ in our body. So you wouldn't feel symptom unless it is less than 1.5 centimeters. So 50% would be enough for your function. So from 30 to
Hmm.
1.5, it would be more than 5. Less than 1.5, it would be mild stenosis. From 1 to 1.5, it's moderate stenosis, and less than 1, it's severe stenosis that's affecting the life or life-threatening.
Gotcha.
So could you repeat the numbers, please?
Yeah, 3 to 5 is going to be your normal.
Mm-hmm.
Less than 1.5 is going to be your mild.
Mm-hmm.
Yeah, and then 1.5 to 1 would be your moderate, I guess, and then less than 1
Yes,
would be your severe.
great. So stenosis, decreased aortic valve area or diameter, and I will be having diastolic failure, which means decreased compliance. It's equal to diastolic failure. We would be having decreased cardiac output, which means systemic hypotension, and this decreased blood pressure could be causing syncopal attacks. Also, this intraventricular hypertension, as a compensation to relieve this hypertension, the body would be making decreased arterial pressure or decreased systemic vascular resistance,
Hmm.
which would be decreasing the blood flow to the coronary arteries and every other organ in our body, which would maybe causing myocardial hypoxia, which would be decreasing the heart blood pressure and also syncope. So you have to remember that syncope is pretty much associated with aortic stenosis. It's very high yield info. So if the patient is suffering from syncopal attack, I should be suspecting neurological systems and the heart, and mainly in the heart, it's aortic stenosis, syncopal attacks.
Aortic stenosis. Gotcha.
Yeah, it's heart failure. It's heart failure for sure. But if for the specific problem, I would be highly suspecting aortic stenosis.
Okay.
Okay. Myocardial infarction and myocardial angina would be causing heart failure, and for sure it's left side. Don't forget that the valves that are affected are the mitral and the aortic. So we are
Mm.
concerned with the left side in
Left
today's
heart
lecture.
failure.
Yeah, great. It is hypertrophied muscle with pretty much decreased compliance. And for sure, I would be having many areas of necrosis and infarctions. So it's decreased aortic valve area, causing pressure overload, which increases the hypertrophy. It's called concentric hypertrophy. Concentric means we are increasing the thickness. In
Hmm.
systolic failure, it was eccentric. You have to know the names. Concentric
Yeah,
for
concentric
diastolic,
thickness. Yeah,
eccentric for systolic.
eccentric.
Great.
Yeah.
Uh, Myocardial oxygen consumption would be increased. Here are the coronaries, and it has branches that deliver blood to the myocardial cells. So consumption would be increased by increased thickness, and also this muscle, thick muscle, would be compressing on the coronary branch. So it would be decreasing also the blood supply to itself. So, but by time, this would
Hmm.
be causing left ventricular failure, but it takes years. And left ventricular failure would be having two symptoms or two main symptoms category: backward symptoms on the lung and forward symptoms on the body by the mean of heart failure and shock, or decreased.
Yeah, yeah, they were
Yeah,
talking. Hmm.
great. So, aortic stenosis. It's the symptoms of decreased blood flow to our organs. So, for brain, it's syncope. For heart itself, it's anginal pain. That's for forward symptoms. The main ones are for brain and the heart. And for backward symptoms, it's pulmonary congestion, shortness of breath, cough, fatigue. So decreased coronary, decreased supply to the brain, and backward symptoms. I don't want to get into specific details to gain some time, or do you want to
Yeah,
get
we've
into?
talked about this before. I think I'm okay. Like why it's causing the left, like feedback or yeah, feedback, backward flow causing
Great,
issues. Yeah, I'm okay with that.
great. So that's prognosis of yeah, how many years the patient could live after these symptoms appear. So if it's chest pain, I could be suspecting or prognosing it's 5 years of life after the symptom appear. It could be 10, it could be one, but it's my medical opinion to be five. Three, syncope, sprains, very important. And if congestive symptoms, it would be just 2 years. It's median survival.
Is that like prognosis based off of no treatment, or is that prognosis with treatment?
I believe it's with no treatment, because with
Yeah, okay.
treatment, I could be replacing this aortic valve and the patient
And
could
then
be
yeah,
having a very normal
normally.
life.
Gotcha. Just making sure.
Great.
Yeah, because if you get chest pain and then you only have 5 years to live, yeah, that doesn't sound right to me. There's a lot of things you can do to
Yes,
fix it, at
exactly.
least.
Exactly. Yeah. Yeah. It's just simple. It's I just um, predicted it to be without treatment, because for sure I've seen patients with these symptoms living a lot, even in
Yeah.
developing countries like in my case. Okay. Do you hear me well?
Yeah, I can hear you fine.
Okay. So for uh, in my cardiac exam, I would be doing auscultation for sure. It's my main
Hmm.
examination. I would be hearing
Yeah.
mid-systolic ejection murmur. Why it's mid-systolic? Why it's not a holosystolic?
Why is it only during mid-systolic?
Mhm.
Um, I'm assuming we're talking about aortic stenosis, so I'm assuming it's like just once it opens, you're not really having any kind of changes in sound anymore. It's only the initial when it's like opening that it sounds different, I
The
guess.
sound is in the stage of flow through the aorta. And systole,
Low in the aorta.
yeah,
Hmm.
this is the whole systole. We have the first part of systole, which is called isovolumetric contraction phase. It's just contraction without opening the aortic valve. And we have
Oh yeah, yeah.
the
Gotcha.
last part, we have a little flow over the aorta. So the main amount of blood is flowing in the mid systole, and flowing in a good way,
Mm,
flowing in a like a straw. I'm blowing a straw. It wouldn't cause any sound. That's like the normal aorta. Blood flow through the normal aorta this wide way without any sound. But if I have a stenosis in this straw, a stenosis or something, yeah, it's like you know, referee used something to make sound with, it's just a stenosis to make the sound.
yeah, yeah. I have an idea what you're trying to say.
Good. I believe I should have be taking more English courses.
No, it's fine. It's fine.
Okay.
Gotta read in between the lines.
So high pitched aortic ejection click. Ejection click, it's the sound of opening of the aorta. If it's stenotic, it
Gotcha.
means,
That's the
yeah, it's very rigid aorta. So it would be opening with a sound. If it's like a rubber, normal aortic valve looks like a rubber. So it opens without any sound.
Gotcha. Yeah.
If it's stenotic, it would
No
be,
sound.
yeah, stiff. So it would be having opening sound, which is, it would be occurring right here. It's called ejection click. By the way, I have been teaching it and I have been told about these things many times, but I have ever noticed it while auscultation. It's very hard to notice, like it would be occurring in
Yeah.
just a couple of
Same.
milliseconds. Yeah, yeah. So you have to know it, but I believe you wouldn't be able to listen for it.
Gotcha.
Split S2 because this stenotic aorta, S2 is has two components. It's pulmonary
Yeah.
component and
Pulmonary
aortic
and
component.
yeah.
Yeah.
Uh-huh.
Normally, they occur just the aorta and after it, exactly the pulmonary. So it's almost the same time. But
Hmm.
when I have aortic stenosis, it's taking a lot of time to push through the aorta. So the aorta would be closing a couple of milliseconds after the pulmonary. So it would be split S2. Like
Mm.
I hearing it like two sounds.
Permanently. Yeah.
Yeah.
Gotcha. Gotcha.
S4 gallop. S4 was for what type of failure?
This was stiffness. So this is diastolic.
Yes, diastolic. It's a sound that I hear just before the start of systole. It's a late diastolic failure. Sorry, it's a late diastolic sound and it occurs in systolic failure. Diastolic failure, sorry. So I have S1 like this, then S2. This is called systole. And I have diastole. In diastole,
Mhm.
I have S3 in the start of diastole. Right here is S3. And right here is S4. So in MCQ, in multiple choice questions, when they tell you that I'm hearing a sound before S1 or in the late diastole, then I should be suspecting it is S4 sound. It's in the late diastole. And it's indicative of diastolic failure. In many MCQs,
Gotcha.
he don't tell you it's S4. He's telling you I'm hearing a sound or a murmur in the late diastole. And you should be knowing it's
Late
S4.
diastolic.
We have something, it's very hard to know. It's sustained bifid left ventricular impulse. Bifid means two. So like I'm hearing the contraction of left ventricle as two sounds. What do you think is happening, making me hearing it's like two sounds?
Mm. Left ventricular impulse. Oh, so you're carrying two. Huh. I'm not really sure what would be causing the double like sounds to be happening.
So,
I guess.
okay. So we are having a very thick muscle of the left atrium. So I should be having
Mhm.
a very strong atrial contraction to push. So
Okay.
this
Yeah, to
this
push
Buffett
it.
sound, double sound, is the sound of atrial contraction and after it ventricular contraction. That's the Buffett sound because we have diastolic failure.
Yeah. So it
Good.
just sounds louder, I guess, because you're contracting louder. In other words, like you're having both of these sounds be louder because the fact that the atrium has to push more or has to work more,
Yeah,
as
but
well as the left ventricle has to work more.
yeah, but it's not louder. Actually, the atrium is before the ventricle couple of milliseconds. So it's Buffett. It's like two sounds. It's not one sound that's louder. It's two sounds, two
Gotcha.
pushes. We have something
Okay.
called
Okay.
pulsus parvus etardus. Parvus in Latin means decreased volume. So the pulse has decreased volume because of stenosis, and it is tardus means delayed. It's stenosis causing decreased volume, and also stenosis causing the ventricle to take a lot of time to push through the stenotic. So it's delayed pulse. Pulses, parvus, etardus, it's very high yield, although it occurs only in severe cases, by the way.
Only
Severe,
severe cases. Okay.
yeah, yeah, it's affecting, it's affecting your blood coming to your organs. The blood is very low volume and very delayed. So yeah, it's in severe cases, in severe aortic stenosis.
Gotcha.
That's pulsus parvus retardus. That's the normal right here. It's the abnormal. It is low amount of blood, low pulse, and also delayed in time.
And also delayed. Yeah, you did the stiffness. Okay, that makes sense.
Okay. Can you tell me what's the abnormality right here in this
Uh,
ECG?
yeah, so we have leads, what, one, three, V1, V5, V6, which is what, lateral or anterolateral issues. Looks like you have the I forgot the J wave, I believe that's what it's called on lead one, which is causing that like a history of maybe an issue going on, like a history of maybe an MI. There's an inverted T wave as well. Uh, yeah, you have the J wave on lead one, which is not normal. So previous MI, previous anterior lateral MI, and then with a no, that's not a inverted, what's it called? T wave. I thought it was, but it's just the way the lead looks. Um, I guess yeah, just like you have a history of something of like an MI on the anterior lateral, not R wave
Okay,
progression.
so practice makes perfect. So you have to be
Uh-huh.
seeing lots of ECGs. I don't remember rules, but for me, I don't remember rules very much. But I have seen hundreds of ECG. So when I take a look,
Yeah,
after I take a look at this, I found that yeah, I think this V5 and V6 are pretty much taller than I think than the previous
yeah,
ECGs
it
I have
should be
seen. Yeah, they are pretty much taller, and I know that a taller ECG means a thicker wall
hypertrophy. Yeah.
yeah, so it's hypertrophy. So but the main finding I'm seeing right here, it's hypertrophy, and hypertrophy means it's left ventricular also, because it's
Hmm.
V5 and V6 mainly,
Yeah,
and V1
those are
is actually is the mirror image of V6, by the way. It's a mirror image.
yeah. That's why it's inverted. Okay, it makes
Yeah.
sense.
Um. So yeah, that's I believe that's the main points right here. It's a left ventricular hypertrophy. That's make me suspect it's aortic stenosis, but I need to make sure by echo. Echo would be seeing the aortic valve and measuring its surface area or its width.
Yeah.
Okay.
Okay.
So it's left ventricular hypertrophy in ECG right here. Yeah, I believe he's describing this ECG in those words, I believe. So it's left ventricular hypertrophy.
Hmm.
Um, and maybe left atrial enlargement, maybe, but I'm not seeing it very well. It should be a much different B wave, but yeah. And yeah, it could be a heart block, but in this ECG, I'm not seeing
Okay,
heart block. It
so
would be prolonged BR interval, but I'm not seeing any prolongation right here. Do you see any prolongation?
yeah,
I don't
fair
believe
enough.
so.
I don't. It looks
Okay.
like just one square box, and it's yeah. So that's normal. Yeah.
Okay. I believe prolonged BR interval would be in acute attacks. So it's a
Acute
diagnostic.
attacks.
Yeah, so it's a diagnostic for rheumatic attack or the rheumatic fever itself, the disease itself, not the scar. The heart valve problem is the scar of the disease, not the disease itself.
Gotcha. Yeah.
Uh, the meeting is ending. So this echo showing hypertrophy of the muscle. You don't have to know echo. Actually, I don't know it very much. I'm not a cardiologist. It's stenosis and calcification of the aortic valve, this white patches.
Hmm.
And this should be a video to know it. He's seeing that
Yeah,
no
to be able to see what's
cusp
happening.
is
Hmm.
moving. So it's stenotic, it's rigid cusps. Treatment, that's why we have very long life expectancy in those cases. Open procedure, sternotomy scar, or transarterial repair of the valve
That's
by
valvular repair.
pumping a balloon. Just, it's dilating the valve, but it's not very successful.